Hello, everyone. My name is Cassandra,
My name is Eric.
My name is Rodney.
My name is Andrew.
and today we're going to be doing our presentation on the neuropathology of spinal cord injuries. In order to talk about this movement disorder, we must first define the spinal cord and what its functions are in our everyday life. So, the spinal cord itself is a bundle of nerve tissue that extends from our brain all the way down the lumbar spine, typically to about that L2 region right here, if you see on the figure on the right. So, some of its functions include receiving signals from the body, such as the sensation of touching a burning hot stove or a really sharp item touching you, and that sensory information will be sent through the spinal cord to the brain so that the brain can react accordingly. The brain will then take this sensory information and devise some sort of response plan for it. So if you do run into that sharp bush or touch a hot curling iron or whatever it may be by mistake, it will send motor commands through the spinal cord out to the rest of the body to get you to pull away that hand or move your body out of the way, kind of like as a safety mechanism there. Lastly, the spinal cord can coordinate reflexes. So these reflexes allow the body to respond to sensory information without waiting for the response from the brain. So even though this process happens in literally milliseconds and we don't even really think about it, we want our reflexes to be even faster than the signal being sent to the brain and back. So as we've learned about in this class, the spinal cord is responsible for reflexes such as reciprocal inhibition, like where the antagonist muscle, so let's say like your tricep, will relax or inhibit itself as the agonist muscle, let's say the bicep in this case, contracts. So like if you're doing a bicep curl, you're not going to have both muscles firing at the same time. The other one on the opposite side will relax. We also have autogenic inhibition, and that's where any muscle that you're using in that specific instance will relax under extreme tension, kind of as a safety response. So if somebody's trying to lift a weight that's way too heavy for them at the time, their body's not going to allow them to do that because that will lead to injury, and our body does not want us to injure ourselves as much as it doesn't seem like it because we get injured all the time because we are imperfect humans, but it's all right. Pretty much that reflex is our safety mechanism when lifting something that is way too heavy. So incidence of spinal cord injury. So this is estimated to affect over 250 Americans alone as of studies done in 2020. It's caused by local spine deformation due to direct compression on the spine, and this is seen as a primary injury or as a secondary injury due to side effects of another injury. So an individual can experience hemorrhages or ischemia, which causes inflammation or electrolyte imbalances, ultimately leading to that secondary spinal cord injury. And this can occur anywhere from 48 hours after the accident or even months later down the line due to prolonged damage and side effects. Some very common ways that we all think about when we think of spinal cord injury occurring: car accidents, especially if it's a really bad car accident. You can just imagine somebody's spine being really compressed all at once. A really bad fall can make this happen. Even violence such as a gunshot wound can cause this. And there are two different types of spinal cord injury that we're going to talk about here. So in the next slide that Eric will be going in, we'll go more in depth, but pretty much we have incomplete spinal cord injury and complete spinal cord injury. So incomplete spinal cord injury is partial paraplegia. Still don't know if I'm pronouncing that right. Words are hard in kinesiology, as we all know, but that's okay. You'll see that throughout the rest of this presentation as well. Pretty much this is where there is some loss of sensation and voluntary motor control. And for somebody's daily ability, everyday life, it will depend on their proprioception and muscle strength, especially. That's what they'll mainly be working on. Complete spinal cord injury will be complete paraplegia, where there is no sensation below the level of injury. So if you can see in these two different images, if it's complete, and let's say it happens whatever vertebrae this is, everything below that will be where you don't feel that sensation. If it happened a little bit higher up, nothing below that. A little bit lower down, nothing below that. So it really depends on where that complete spinal cord injury takes place. And incomplete, you can see it's really only on that one little side there in that really small spot, but it's different for every individual. For those with complete spinal cord injury, their ability, if they do end up regaining some of their sensation. We'll be mainly focusing on working up to controlling their center of mass and their base of support. So Eric will take it away with the rest.
Okay, so I'm going to be going over skill performance. The first ones we'll be talking about are balance and gait. So balance depends on the continuous integration of somatosensory, visual, and vestibular impulse, its processing, and targeted motor responses. In patients with spinal cord injury, partial or complete loss of somatosensory perception and or voluntary motor control are the main causes of balance disorders. So we do see that patients with motor complete paraplegia are not able to stand and walk. Generally, these individuals will be using wheelchairs or other assistive devices. This is compared to patients with incomplete spinal cord injury with partial or voluntary control over the abdominal and lower trunk muscles. These individuals, when it comes to balance, are generally a lot stronger in a sitting position, and it is achievable for them. But the transition from sitting to a more postural dominant positions like standing and walking are much more demanding. When you think of gait, we kind of just start walking, we pick up our feet, no problem. And then when we want to stop, we stop. But we'll see that in incomplete spinal cord injury, it's actually the termination of gait is the more challenging than to actually initiate the walking pattern. Next, what I'll be talking about is going to be bowel movements. So can you change the next slide for me? Oh, there we go. So for this skill performance, I know that we don't think of bowel movements as being something super skillful, jumping, running, swimming, but it's really important and we should go over it. So when it comes to spinal cord injury, we're going to see neurogenic bowel. This is going to be constipation, rectal evacuation difficulties, decrease and anorectical sensation, and fecal incontinence. Now, this is going to be due to the interruption of the supraspinal control of the spinal autonomic circuits regulating the colon. Difficult to say, like Cassandra said, kinesiology, right? Now, it's important to understand that both neurogenic bowel and spinal cord injury are comorbidities, meaning that generally these two diseases or injuries go hand in hand. They for sure both take physical and psychological challenges and the quality of life for these patients. Now, for the next slide, we're going to go into the complications with bowel movements. So current bowel management programs are categorized as overly conservative, non-invasive strategies, and surgical treatment. For our conservative treatments, we're going to see lifestyle strategies, digital rectal stimulation, and pharmacological, osmotic, and stimulant laxatives. For invasive surgical interventions, we're going to see implanted neuromodulator devices, right? So these devices can innervate muscles to help with bowel movements. Some advantages that we'll see are going to be the reduced transit time for rectosigmoid and increased frequency of defecation. And the disadvantage is going to be the simultaneous anal sphincter contraction, which can block directly emptying when it's stimulated. So basically, though it's stimulating to help with bowel movements, it can also block them at the same time.
Thank you, Eric. So I'm going to talk about like the current interventions, and there were some of the surgical treatments that I found through the spinal cord injury. One of them were like the spinal decompression. The other was the spinal fusion surgery. And we found out that during the surgery of the treatment, they do implantation of the rods, screws, excuse me, and other instrumental for stability. They also remove all of the excessive fluid, bone fragments, and the herniated disc and the forward objects to take away from the spinal cord and to release more of like the inflammation and the body temperature from it. And then also from the pharmaceutical treatment, we also found that it also counters like Tylenol, Advil, and Aleve to of like the nerves because of the pain for painkillers because it's very, very extenuating. And some of the prescriptions are non-steroid inflammatory drugs, nerve blockers such as methylprednisolone. I'm sorry, guys, it's part of kinesiology. Methylprednisolone is a give me 1 second. It's an IV that goes through your arm, but it has a negative effect and more benefit effect. Pretty much, it goes through your arm. Treatment is supposed to be acute for the spinal cord injury through the past, but it shows more of the side effects such as blood clots, femoral, and from this, it's just not beneficial for someone who has a spinal cord injury. So I wouldn't really recommend it. And then some of the treatments I recommend is physical PT, aquatic therapy, going into the water pool, make sure it's around 70 to 80 degrees in the water, having a structure, focus on muscle strengthening, OT, just working on day to day, like daily activities, so you can slowly gradually into your activities and whatnot. And then resurrection therapy that will also be beneficial. Like just try to be able to be more flexibility with your back and just move side to side and make sure that it's still up to par and you can still do your regular activities that you can do.
All right, guys. So the overall outlook, the spinal cord, as previously discussed, in our presentation, is highly complex and is a crucial part of the body for functionality and motor control, performance, and ADLs. Based upon literature gathered for this research, we have concluded that there are no definitive cure for spinal cord injury, because it depends on the individual and how severe the injury is. And also is based upon the fact of whether the injury was incomplete or complete, as explained in our previous slides. However, in the past several decades, there has been significant progress in improving patient survival and emergency care and expanding the range of rehabilitation options. Some examples include cellular therapies such as bone marrow transplant and stem cells for regeneration of the spinal cord. Also Schwann cells to control neuropathic pain due to the injury. Researchers also have found that the Schwann cells were present in the regenerated areas in experimental models of spinal cord injury. So they believe that Schwann cells help with the regeneration process, and it regenerates the axon with various neurotrophic factors, which deemed to exhibit distinct motor or sensory phenotypes. Another interesting research article that we ran across is neuroprosthetics. And we found that the main goal for neuroprosthetics is to restore the ability to act in a person's environment. And this is more targeted towards tetraplegic patients. And so what this neuroprosthetic does is it's an implantation of 2 small silicone chips into the brain. And this chip will signal a movement to occur by bypassing the damaged spinal cord area. So the researchers hope that this chip will allow successful performance in ADLs and within these patients that have lost motor functions. Spinal cord injury research should focus on preventing the loss of function and on restoring lost functions. This includes sensory, motor, bowel, bladder, autonomic, and sexual functions with the elimination of complications, particularly pain, spasticity, pressure sores, and depression, with the ultimate goal of fully restoring the individual in all levels of activities and function before the person had his or her injury. Technical advantages and innovative research, as well as technological advances will help improve and find ways to better treat patients with SCI. In our opinion, the future for SCI treatment looks promising. And yeah, that is our presentation.